Um, Thank you very much, Dr. Kiapi and Dr. Tahir, for those kind introductory remarks. I'd like to thank KRA for inviting me to give this talk. I know I was asked several times yesterday that I've given this talk so many times. So I decided to make this slightly different. We are basically going to go through the cases that I have personally managed over the past 2 years. And there'll be a few questions. Of course, there are no right or wrong answers, so please feel free to pitch in. So we'll be talking about the cardiorenal syndrome today. Okay. So the first case is going to be a case that I managed in 2018, when among the first few days when I joined MP Shah Hospital. So this was a 60. She's now 66. Thankfully, she's okay. She's alive and well. 60 at that time, she was a 64-year-old female known to have coronary artery disease, diabetes mellitus, hypertension, chronic kidney disease, and hypothyroidism. She had had angioplasty done in 2011, and then subsequently she had gone to India and had a bypass graft surgery done in June 2016. So her medications at the time of admission were atorvastatin, ezetimibe, aspirin, clopidogrel, telmisartan, amlodipine, bisoprolol, torsemide, and insulin glargine. Her serum creatinine post-CABG was 131 micromoles per liter. So she had actually presented with in respiratory distress. She had dyspnea on exertion and orthopnea for 1 day. And when we saw her, she was in marked respiratory distress with post-Krebs bilaterally, with elevated blood pressures of 211/93. She was tachycardic with a heart rate of 101 and an SpO2 of 98%. Her ECG showed an old left bundle branch block, so there was not any change from the previous ECG. Her kidney function showed a potassium of 5.5, an elevated urea of 12.8, and a creatinine of 194, giving her an EGFR of 23 mils per minute at that point in time using the CKD-EPI formula. Her hemogram showed that her HB was slightly low at 11. The rest of the parameters were all within normal range. Her pro-BNP was markedly elevated at 19,000. Troponins were high at 40. And an urgent 2D echo bedside that was done at that point in time showed that she had an ejection fraction of 40%, apical, septal, and posterior wall hypokinesia with a severe MR and a moderate tricuspid regurgitation with mildly elevated pulmonary artery pressures of 40. The urinalysis showed a protein of 1+. There were no cells, no glucose. There was no change from the previous urinalysis in 2016. So this patient was admitted into the intensive care unit. She was started on furosemide, 40 milligrams twice daily. The doctor bound the potassium with insulin, shifted the potassium with insulin dextrose, and she was started on the GTN infusion because of the hypertensive emergency. The telmisartan was thankfully held. Now, unfortunately, her urine output was only 200 mils in 12 hours after admission, and a serum creatinine after 12 hours, it actually bumped up to 274 micromoles per liter. So does this patient have cardiorenal syndrome type 1? Or is it a cardiorenal syndrome type 2, or type 3, type 4, or type 5? So when you look at cardiorenal syndrome, it's a very difficult to define, because it basically encompasses complex multifactorial facets, including physiological, biochemical, and hormonal, as I will go through. Now, initially in 2004, the National Heart, Blood, and Lung Institute had basically defined cardiorenal syndrome as damage that occurs to the kidney because of the diuresis to relieve the congestive symptoms of heart failure. Okay, but subsequently we found that this was not entirely true. It was not only because of the diuresis that led to the renal dysfunction, and basically we now know that even renal dysfunction can lead to cardiac dysfunction as well, and this is why we have the type 3 and the type 4 cardiorenal syndrome, or renocardiac syndrome as it is commonly called. So following a consensus conference in 2008, Professor Ronco et al. Professor Ronco and his group defined cardiorenal syndrome as disorders of the heart and kidneys whereby acute or chronic dysfunction in one organ may induce acute or chronic dysfunction in the other. Now, one important thing to note is that it is not static. So if somebody has type 2 cardiorenal syndrome, which is whereby you get chronic conditions of the heart like chronic congestive cardiac failure giving you chronic kidney disease, the patient can tip over into type 1, like what happened with our patient. Remember that our patient basically had type 2 cardiorenal syndrome. The patient had chronic cardiac conditions and then subsequently came in with an acute event that basically tipped them into acute decompensated heart failure and subsequently acute kidney injury. Okay. Sorry. Okay. So as I say that there are 5 types of cardiorenal syndrome. There's cardiorenal syndrome type 1, type 2, type 3, type 4, and type 5. So type 1 is basically acute cardiorenal syndrome. So any abrupt worsening of cardiac function, for example, acute congestive cardiac failure or acute myocardial infarction, will basically lead to acute kidney injury. Type 2 is chronic abnormalities of cardiac function, like chronic congestive cardiac failure, causing progressive and permanent chronic kidney disease. Cardiorenal syndrome type 3, or is called acute renocardiac syndrome. So when you get acute worsening of your kidney function, like acute kidney injury, such as because of ischemia or rapidly progressive glomerulonephritis, causing acute cardiac disorders because of overload or because of arrhythmias. You have cardiorenal syndrome type 4, which is your chronic renocardiac syndrome, which is basically chronic kidney disorders, subsequently leading to chronic cardiovascular disease or chronic congestive cardiac failure. Then we also have cardiorenal syndrome type 5, which is basically diseases that affect both the kidney and the heart simultaneously, like your diabetes, high blood pressure, or sepsis. Now, why is it important? I mean, before 2004, there was no entity like cardiorenal syndrome. So it is important because mortality is increased in patients with heart failure who have a reduced glomerular filtration rate. Okay. Now, patients with CKD also have an increased risk of atherosclerotic cardiovascular disease and heart failure. And we all know that in patients with CKD, cardiovascular disease is the most common cause of death in these patients. Okay. And acute or chronic systemic disorders can cause both cardiac and renal dysfunction. So we know that AKI predicts death, rehospitalization, and the chance of ending up on dialysis. So irrespective of whichever formula that you use, either your, whichever criteria that you use, either your Reifel criteria, your Akin criteria, or your KDIGO criteria, as the stage of the acute kidney injury worsens, so does your odds ratio of your death, rehospitalization, or dialysis worsen. Okay, the incidence of cardiorenal syndrome type 1, unfortunately, this is the most commonly studied cardiorenal syndrome. And we know that for cardiorenal syndrome type 1, acute decompensated heart failure is the most common cause, followed by cardiac surgery, and acute coronary syndrome is number 3 in that list. Okay, so the patients who are at high risk for cardiorenal syndrome type 1 include those with pre-existing CKD, patients with diabetes, patients with hypertension, patients who are given high-dose diuretics, patients who are given iodinated contrast, increasing age, and those who have anemia. Now, if you look at our patient basically had pre-existing chronic kidney disease. Our patient had diabetes. Our patient had hypertension. Our patient was given high-dose diuretics, was given furosemide 40 milligrams twice a day. She was elderly, and she had anemia as well. So she had all the risk factors to basically get cardiorenal syndrome type 1. Okay. Now, again, looking at baseline kidney function as a predictor of cardiovascular mortality and heart failure hospitalization, you can see that for both creatinine and the urea, as the creatinine and the urea increase, so does your risk of cardiovascular mortality and hospitalization for heart failure increase. Okay, this was an old study which was done in 2012 by McAllister et al., which was basically looking at the association between eGFR and all-cause mortality in patients with heart failure. And the patients were basically categorized into heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Now, what they found was that they basically got a positive association with worsening estimated GFR with mortality in HFrEF patients, which is heart failure with reduced ejection fraction. When they looked at heart failure with preserved ejection fraction, they did not see an increase in mortality that was statistically significant as the eGFR worsened. However, a much later study done by Unger et al., actually, which was a retrospective 2-year study, showed that in patients who have got heart failure with preserved ejection fraction, as your CKD worsens, so does your risk of mortality. So basically, for both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, when you get chronic kidney disease or renal dysfunction, your outcomes are much worse. Okay. So what is the next step in our patient? Remember, this is a patient who has come in with congestive cardiac failure, fluid overload, her creatinine has bumped up. She has not responded to furosemide 40 milligrams twice daily. So what should you do? Should we increase the furosemide to 80 milligrams twice daily? Should we add a vasopressin receptor antagonist like tolvaptan, which causes aquaresis? And there are some trials that have shown that it can reduce your symptoms, but unfortunately has no mortality benefit. Stop GTN and change to nesiritide. Or should we go ahead and dialyze her and ultrafiltrate? Or should we start low dose dopamine? So how many go for increasing the furosemide to 80 milligrams twice daily? I think it's only Dr. Twair who has been attending my previous talks, because we've talked about the ceiling dose of diuretics. Okay, so unfortunately, I don't have the time to go through all of them, so we'll just go straight to what I did. I increased the furosemide to 80 milligrams twice daily. We continued with the GTN infusion. The serum potassium reduced to 4.8 millimoles per liter. The urine output increased to 1.2 liters. So we can see that now there's a diuretic effect that we're getting with our increase in the furosemide. The patient's symptoms improved. However, her serum creatinine basically worsened. So on the 5th day of admission, the serum creatinine was 417. And we know that this happens all the time as a collateral damage when we increase our diuretic effects. Okay. So subsequently, on the 10th day post-admission, her serum creatinine actually reduced to 270. And this happens and because of several reasons. One of them is because you are basically offloading the heart. Your cardiac function is improving. Okay. So when your cardiac function improves, your perfusion improves, and subsequently you do tend to get improvements in your kidney function. 2 is that the edema that you're seeing outside is also happening within the body as well. So when you are reducing that edema outside, you're also reducing the congestion in the kidney as well. And this subsequently improves your perfusion to the kidney. So her serum potassium was normal. Her eGFR was 16 mils per minute. Her symptoms had improved. She was ambulating. However, her BPs were persistently high. So what's the next step in this patient? Remember, this patient initially was on telmisartan, which we had stopped. Okay. So should we restart the telmisartan? Should we change to enalapril? Or should we start sacubitril valsartan? At that time, in 2018, the sacubitril valsartan was a new kid on the block. Or we should not start the ACE inhibitor or ARB stroke ARNI as the eGFR is 16 mils per minute. How many of you would go for option 4? Dr. Wala, you'd go for option 4. Yeah, I know who would go for option. Okay. So what's the evidence? So the Paradigm heart failure trial, I believe, changed the landscape of heart failure at that point in time when it was published, when the results were released. And this was a prospective comparison of an ARNI with an ACE inhibitor, okay, to assess for mortality and morbidity in patients with heart failure. So basically, they took all patients who are 18 years and above, who had got New York Heart Association class 2 to 4, who had heart failure with reduced ejection fraction and an elevated pro-BNP or an anti-pro-BNP. And these patients were on the standard of care for heart failure at that point in time. They should have been on a beta blocker or a mineralocorticoid receptor antagonist as recommended by the guidelines. They had to have a normal blood pressure and an eGFR of 30 mils per minute. This was at that point in time with a normal potassium. Okay. There was a single blinding period whereby all the patients were given enalapril initially, then subsequently sacubitril valsartan at 100 milligrams twice daily and sacubitril valsartan 200 milligrams twice daily. The reason for this was basically to make sure that the patients did not have the side effects. Okay. And then subsequently they were randomized to either sacubitril valsartan or enalapril, and they were subsequently followed up. And what they found for the primary outcome was basically there was a 20% risk reduction in the patients in the sacubitril valsartan arm as compared to the enalapril arm. And remember that these patients are on standard care of therapy for heart failure, which was a standard of care at that point in time. So addition of sacubitril valsartan actually reduced your mortality further together with the standard of care by 20% as compared to enalapril. So this was quite significant. Okay. The death from cardiovascular cause again was 20% lower in the sacubitril valsartan arm as compared to the enalapril arm. And hospitalization for heart failure had reduced by 21% in the sacubitril valsartan arm as compared to the enalapril arm. And for all of those three endpoints, they were all statistically significant. Death from any cause was also lower by 16%. Okay. Now, how about the changes in your creatinine or in, worsening of your creatinines or kidney function? Now, what this study actually showed was that there was a slowing down in terms of worsening of your eGFR when the patients who are put on the sacubitril valsartan arm as compared to those who are put on the enalapril arm. And again, this was statistically significant. But remember that this was not the primary outcome, so we cannot make a conclusion from this. We can just generate a hypothesis from this. One important thing to note was that there was a modest increase in the urine albumin creatinine ratio for these patients, okay, in the sacubitril valsartan arm as compared to the enalapril arm. So for both of them, the USCR increased up to this point, and then subsequently for the enalapril arm, it reduced, while for the sacubitril valsartan arm, it basically remained constant. And the hypothesis is because of the natriuretic peptides, which are basically vasodilators. So what they tend to do is that they will increase your glomerular endothelial permeability and hydraulic conductivity, and there will be alterations in the renal tone. So this basically increases your intraglomerular hypertension and possibly leads to proteinuria. Okay, so this was a trial that was not specifically looking at renal dysfunction. Okay, remember that our patient has got heart failure, renal dysfunction, diabetes, and hypertension. So this was another trial that was published again towards the end of 2018, and this was a UK HARP3 trial, which was comparing sacubitril valsartan with another ARB, irbesartan, in patients with chronic kidney disease who had hypertension. So this was a randomized double-blinded trial. They had more than 400 patients who are in CKD stage 3 and 4. And the primary outcome was basically looking at the eGFR at 12 months. And what they found was that over the 12 months, the patients who are in the sacubitril valsartan arm and irbesartan basically had similar effects on kidney function and albuminuria. But the patients who are on sacubitril valsartan had additional effects of lowering the blood pressure and cardiac biomarkers like your proBNP in chronic kidney disease. Okay, so this basically shows this, that the decline in your creatinine or your, decline in your eGFR is basically constant for both the groups. Okay, sorry. So I'll move to case 2. This was another case we had managed again in 2018, a 64-year-old male. He was basically a readmission, had got progressive dyspnea on exertion, New York Heart Association class 3, had been admitted a month before due to a cardiac arrest, secondary to anterolateral STEMI. He had a PCI done in that admission, and he was on aspirin, ticagrelor, atorvastatin, carvedilol, and ivabradine at that time. Unfortunately, he had developed a complete heart block, he had a temporary pacemaker inserted, and the beta blocker and the ivabradine were subsequently stopped, and the heart block resolved. On discharge after the first admission, his EF was 30%. Now, for his current admission, his blood pressure was 110/80, heart rate was 88, and an SpO2 of 96%. When I examined him, he had bibasal crackles with an elevated JVP, quite elevated proBNP. His urea electrolytes and creatinine were within normal range. So again, I started him on IV furosemide 40 milligrams twice daily, restricted his fluids. However, he was noted to have worsening renal function. Again, his creatinine bumped up to 160 from normal. Okay. The 2D echo showed that his EF had actually reduced from 30% to 20%. He had the same pattern of regional wall motion abnormality as the previous echo. However, he had symptomatic improvement after 2 days of IV furosemide. He was hemodynamically stable. His blood pressures were stable. His creatinines remained the same. So we decided to start him on sacubitril valsartan, the lowest dose, 50 milligrams twice daily. Unfortunately, after the first dose, his blood pressures dropped to 80/50. Okay. So this is expected because when they looked at the paradigm heart failure trial, the safety outcomes are basically looking at hypotension and hyperkalemia. And we can see that for, okay. Yeah, so we can see that for the hypotension, the incidence of symptomatic hypotension was much more in the sacubitril valsartan arm as compared to the enalapril arm. And the systolic blood pressure actually dropping to less than 90, even though the numbers were lower, but it was still statistically significant in the sacubitril valsartan arm.
The reason why I'm asking,
Looking at hyperkalemia of more than 5.5, it was the same in both arms, but for 6.6, 6.0, it was actually more in the enalapril arm as compared to the sacubitril valsartan arm. So patients whom we start off on sacubitril valsartan, we have to be a bit more cautious because they have been shown to have instances of hypotension, and we need to be more cautious with when we start them and monitor them more closely. However, when it comes to hyperkalemia, we can see that for ACE inhibitors, the enalapril actually had a higher incidence of significant hyperkalemia as compared to sacubitril valsartan. So the sacubitril valsartan was initially stopped. The patient's blood pressure stabilized at 90/60. He was discharged on furosemide, atorvastatin, aspirin, and ticagrelor. Remember, we couldn't discharge him on a beta blocker or ivabradine because of the heart block that he had had. He was seen as an outpatient and the blood pressures were stable. So we subsequently started him on sacubitril valsartan 50 milligrams once daily. He tolerated it quite well. And then subsequently, we have increased it to twice daily. Blood pressures remained stable. His symptoms improved to New York Heart Association class 2, and his EF improved from 20 to 30%. And he couldn't tolerate a higher dose than the 50 milligrams twice daily. So his creatinines also remained stable at 140. I forgot to put that in. So how common is hospital admission for worsening renal function in patients with heart failure as compared to, and what are the challenges faced in individualization of the treatment? So we know that patients don't come to us with renal failure, those who have heart failure. Most of them basically come in with heart failure, and they tend to get kidney complications when we are doing, when we start them on treatment. So it's not a very common cause of admissions, and hyperkalemia is one of the most common complications that we tend to see. The challenges that we tend to see is basically how do we optimize the diuretic therapy, keeping in mind that it may worsen the renal function. Should we give ACE inhibitors or ARBs because of the fact that we're worried about the rise in creatinine? The BP control, as we had seen in my second patient, and how do we manage the worsening heart failure as well? Okay. So the third patient that I have is basically a 51-year-old female who had no known comorbidities. She had a history of left orbital meningioma, which was excised and cured in 2017. She had presented to me with a cough for 1 month and a dyspnea on exertion with the New York Heart Association 2 to 3. She had intermittent lower limb edema with orthopnea for 1 month. She was being treated for asthma for that 1 month because of the fact that she had a family history of asthma. She was not a non-diabetic or hypertensive, and she was a non-smoker and did not take any alcohol. So when I examined her, she was basically sick looking. Her blood pressures were normal. She was tachycardic. Saturations were slightly on the lower side, and she was tachypneic with a respiratory rate of 26 per minute. And when we examined her, she basically had crackles in the mid and lower lung zones. She had features of heart failure, and she had a hepatomegaly 4 centimeters below the costal margin. So when you look at her bloods, the hemogram was within normal range, the CRP was within normal range, her kidney function, her renal function was within normal, LFTs were normal, but her pro-BNP was quite elevated, and her troponins were elevated as well. Her HbA1c was also within normal range. Lipid profile was within normal. On the ECG, she had Q waves in layers 2, 3, and 4. I think I should be given more minutes because this keeps on interrupting me. I hope nobody has any objections to that. So her 2D echo actually showed that she had global hypokinesia with a severely impaired left ventricular ejection fraction of 30%, diastolic type 2 dysfunction, and a dilated left atrium with significantly elevated pulmonary artery pressures. And a CT scan done showed that she had got cardiogenic pulmonary edema. So the coronary angiogram basically showed that she had coronary artery disease. Okay, she was started on aspirin, clopi, IV furosemide, atorvastatin, ramipril, and enoxaparin. The symptoms improved. We managed to get her off the oxygen. She was started on cardiodinal after the symptoms improved. While still in hospital, we stopped the ramipril and gave her 36 hours, after which we started the sacubitril valsartan. Now, it is very important to remember that when you want to start sacubitril valsartan, you have to stop your ACE inhibitors for 36 hours to wash out the ACE inhibitors. Otherwise, your risk of angioedema significantly increases. Okay, we had also started her on enoxaparin as well. So she was subsequently discharged, and within 2 weeks, we reviewed her. Her kidney function was normal, and she reported significant improvement in her symptoms. The sacubitril valsartan was increased to 100 milligrams twice daily. After 1 month, it was increased to 200 milligrams twice daily. And after 2 months, we basically did an echo, which showed that her EF had actually improved to 35%, and her PA pressures had also come down as well. And a pro-BNP at that time was 800. Remember, initially it was 4,278. So review after 6 months showed that her symptoms had again significantly improved. Her orthopnea had completely resolved. She was now in New York Heart Association class 2. The serum potassium and creatinine remained stable. And her echo now showed that her EF had improved from 35 to 40%. Her PA pressures had now improved again more to 40, they come down to 40 millimeters of mercury. And she had a mild TR with a moderate MR. So this trial was basically looking at whether there was any association of changes in your pro-BNP following initiation of sacubitril valsartan with the cardiac structure and function in patients with heart failure with reduced ejection fraction, like what was happening in our patient. And what they found was that when they started the patients on sacubitril valsartan, in those who had got heart failure with reduced ejection fraction, they found that there was a reduction in your cardiac biomarkers like your NT-proBNP, and also your structure of the heart failure. I mean, the structure of the cardiac function, structure and cardiac function actually improved as well, as evidenced by your reduction, improvement in your ejection fractions, your improvements in your left ventricular end diastolic volume index, and your end systolic volume index as well. And the same thing happened to our patient as well. You can see that the pro-BNP reduced, your ejection fraction actually improved as well. The Pioneer heart failure trial was basically looking at starting off an ARNI in acute decompensated heart failure during the admission before discharge, which is what we had done. And this was basically a multi-center randomized double-blinded active control trial. They had more than 120 sites in the United States, and they had patients with heart failure with reduced ejection fraction who were randomized to sacubitril valsartan or enalapril after hemodynamic stabilization. So they had more than, they had 440 patients in the sacubitril valsartan arm and 441 in the enalapril arm. And the primary efficacy outcome was the time average proportional change in the pro-BNP with the key safety outcomes of worsening renal function, hyperkalemia, and symptomatic hypotension and angioedema. And what they found was that the changes in the pro-BNP concentration in the sacubitril valsartan arm are significantly lower as compared to the enalapril arm, which was statistically significant. And if you look at the key safety outcomes, they are both equal in both the arms, including your worsening renal function, hyperkalemia, symptomatic hypotension, and angioedema. And in an analysis of exploratory clinical outcomes, the in-hospital initiation of sacubitril valsartan was associated with a lower rate of rehospitalization for heart failure, and at 8 weeks in enalapril therapy. So meaning that it is safe to start patients who come in with acute decompensated heart failure on sacubitril valsartan. So if you look at the cardiorenal mechanism, these are my last 3 slides. If you look at the cardiorenal mechanisms in acute heart failure, as I said, that this is the most studied cardiorenal syndrome. Patients who get either left heart dysfunction or right heart dysfunction, remember that there is the myocardial crosstalk. So left heart dysfunction can lead to right heart dysfunction, and the converse is also true. So when you get right heart dysfunction, you tend to get an increase in your pressures to the your central venous pressures, which basically lead to increase in your renal vein pressures because of the backflow, and subsequent interstitial edema, which leads to acute kidney injury because of your reduction in your renal perfusion pressures as well. The renal vein pressures basically also, as I said, lead to a decreased renal perfusion pressures. Now, left heart dysfunction basically leads to a reduction in your stroke volume and your cardiac output. And this subsequently leads to a feedback mechanism which increases your vasoconstrictor. So it basically leads to increase in your vasopressin, your renin-angiotensin-aldosterone system, your sympathetic nervous system, and your endothelins. Now, simultaneously, you also tend to get an increase in your vasodilatory natriuretic peptides. Your ANP and your pro-BNP are also increased as well. Your kinines are also increased. However, this, if it is left unchecked, if your heart failure is not treated correctly and aggressively, the vasoconstrictor effect basically overcomes the vasodilatory effects, and this subsequently leads to and acute kidney injury. Okay, so when we now tend to look at heart failure is a state of neurohormonal imbalance. So you tend to get more of vasoconstriction effects as compared to your vasodilatory effects. So what we need to do basically is to move away from the vasoconstrictive effects and go more towards the vasodilatory effects, what we call neurohumoral modulation. So we need to increase our ANP, pro-BNP, and your kinins as well, and reduce the effects of your angiotensin. I'm not saying that we eliminate them. I mean, we should eliminate the effects of your angiotensin 2, your sympathetic nervous system, and your endothelins. And this, I believe, will improve our outcomes in both heart failure and renal dysfunction, what we call the cardiorenal syndrome. So in conclusion, the cardiorenal syndrome is very complex, as I mentioned. It's related to both diminished renal perfusion and increased venous pressures. Therapies should target the neurohumoral modulation, and the ARNIs basically play a very important part. They've been shown to reduce mortality when added to the usual therapies in heart failure with reduced ejection fraction. Can be started in patients with heart failure before discharge, as evidenced by the Pioneer heart failure trial. And the ARNIs help to stabilize and improve renal function in patients with cardiorenal syndrome, as I've demonstrated. Thank you very much.